Hello. On behalf of Natus Medical Incorporated Balance and Mobility, I welcome you to today's eSeminar on the topic of concussion, featuring Mike Hales from Raleigh Neurology. A few reminders before we begin. All lines are muted to ensure a quiet virtual meeting room. We aim to allow time for questions before the end of the hour. Kindly type your questions into the chat box and Mike will answer them, time permitting. Finally, the recording of today's eSeminar will be posted on our website, and a link to the recording will be sent via email to all participants. Without further delay, I'm pleased to introduce our speaker, Mike Hales. Mike specializes in concussion management at Raleigh Neurology Associates, Raleigh, North Carolina. Mike is passionate about his concussion outreach program and works to educate the community about head injury and the importance of accurate assessment and management for safe return to play decisions. Mike joined the U.S. Navy after completing his associate degree in computer science. He left the Navy in 1988 and accepted a position as a software engineer at Alcatel-Lucent, where he worked until joining Raleigh Neurology Associates in 2010. Mike received on-the-job training on the Neurocom Smart Equitest and began working with neurology patients diagnosed with disorders such as multiple sclerosis, Parkinson's disease, and concussion. His interest in concussion grew quickly, and he now manages Raleigh Neurology Concussion Clinic.
Thank you, Mary. First of all, I'd like to say I was truly humbled and honored to be asked to speak today. I really appreciate this opportunity. I've been very fortunate to be mentored by Dr. John Wooten. We have attended many conferences and presentations on the topic of concussion and been able to meet and hear many knowledgeable speakers. I currently assess adult and pediatric concussion patients here at Raleigh Neurology, as well as perform some ADHD testing as well as some cognitive testing. Now I'm going to talk about our learning objectives for today. First of all, I'm going to describe the steps that we went about creating our concussion management program here at Raleigh Neurology. Then we'll talk about some benefits of using the dynamic visual acuity testing with our patients. Then some potential negative consequences or mismanaged or undetected concussions. And then we'll move on to some marketing tips for successful promotion of concussion management services. A little bit about Raleigh Neurology. We have 27 doctors here, adult and pediatric, 19 physician assistants and nurse practitioners. We treat, obviously, many neurological disorders. We have the concussion clinic, sleep medicine lab, infusion suite, MRI, EEG, a pain center, and recently just started rheumatology. First of all, I'd like to start out with the American Academy of Neurology's definition of concussion. A clinical syndrome, a biomechanically induced alteration of brain function, typically affecting memory and orientation, which may involve loss of consciousness. The majority of the patients that we see do not involve loss of consciousness. We attend the annual meeting each year at the American Academy of Neurology, and generally their meeting covers all diagnosis, but in 2014 they held a meeting solely on the topic of concussion. It was held in Chicago. This kind of just re-emphasized the importance of concussion. Obviously there's been a lot of media coverage recently with all the incidents going on in the NFL and the problems they've been having with concussions and chronic traumatic encephalopathy. The Academy published some new guidelines in March of 2013, and basically the new guidelines recommend that if you've been suspected with a concussion, obviously be taken out of the game and do not return until you've been assessed by a licensed healthcare professional trained in concussion. I think that's probably the key word. Early on, patients were being treated by people or assessed by people who were not trained in concussion and possibly sent back too early. Obviously, there's a return to play, after all symptoms are gone. Athletes, high school and younger, they have to be managed a little bit differently. Obviously, return to play, and then obviously they take longer to heal, so you really need to keep an eye on symptoms. Some of the original studies were done on college-age students, and their recovery time is much quicker. The younger you are, the longer it takes to heal. It's kind of opposite of the broken bone. Obviously the younger brain is still developing quite rapidly. There's some other topics here of the guidelines. There's some things that we look for in particular. You're more susceptible to have a concussion if you already have a history of concussions. Also, some other things, if you have a history of headaches, you're more susceptible to having concussion. That last bullet there, the first 10 days after concussion appears to be the period of greatest risk. The biggest thing, you don't want to send them back too early. Second impact syndrome, it's a 50% fatality rate in 18 and under. The top bullet there talks about football helmets. There's no evidence that any type of equipment, whether it be for football or soccer, that any single tool can or equipment can help you prevent getting a concussion. It's just a matter of obviously proper technique and that type of stuff, and the equipment being well maintained. The bottom there, it talks about while treating concussion, look for ongoing symptoms. Once again, it just reiterates that the longer recovery period for the younger age kids. Now we're going to talk about our program here at Raleigh Neurology. These bullets here, this is kind of what we go through, and I'm going to speak on each one. First of all, we give each patient a symptom checklist. Then we do a comprehensive intake, some balance testing, vestibular testing, cognitive testing, obviously a doctor's visit, and then we fill out forms for school and return to play. The first one I'm showing here is our initial visit symptom checklist. It has the date of injury on it, and then it asks for the symptoms that they were feeling at the time of injury, and then it also, depending on whether it's the same day or not, usually we see them within 2 to 3 days, normally not more than a week later. It has how they're feeling, and it's the graded symptom checklist. These symptoms were taken right off of one of our cognitive tests called the impact. We have a separate, we started giving a separate sheet to our parents. We found out over time that depending on the age of the child, if they're real young, they may not understand some of the symptoms that they're feeling and not really know how to fill it out. But also as the patients get a little older and wiser, they've learned that they don't want to tell exactly how they're feeling because they know they can't go back to play or return to activities that they want to be doing. For subsequent visits, we still pass out a symptom checklist, but it's only for how they're feeling that day. And we do not give one to the parents after the first visit. The next step is we do a comprehensive intake process. As you can see on the form, it is, we ask a lot of questions. Our first visit, we generally tell parents that it takes an hour and a half to 2 hours to go through everything. So when you come, plan to stay for a while. This is really probably the most important piece of our visit because it allows us to get a lot of information. You can see just general information at the top, but we start when we ask them what kind of grades they make, below average, average, above average. It kind of helps us get a feel of how they might score on the cognitive testing when we get to that piece. Then obviously we ask them about loss of consciousness, and if so, the duration. And then we go into a detailed description of the injury, the mechanism of injury, the symptoms right away. It kind of gives us an insight into possibly the recovery time. We ask about whether or not they've been to the emergency room, had a CT scan done. Then we ask patient and family history. The headaches is question, and the ADHD and the anxiety piece is also plays a big factor into recovery process. Obviously, the family history of headaches, a lot of times, even though the child has never really experienced headaches in the past, with the family history, when you get a concussion, a lot of times it triggers the headaches in the children. So it's something that we have to monitor. Once we think the concussion is cleared, then obviously, there's a possibility that with the trigger to the headaches, they may have to just be treated moving forward. Down in the right-hand corner, we kind of added a little check boxes for the different forms and whether or not we feel that medication is needed or a possible MRI, EEG, physical therapy, neuropsych testing, form of vestibular testing, vision therapies. We also do research studies, so we click that box if we think someone is a possible candidate, and then if we think labs are needed, we check those boxes, and it kind of gives a heads up to the doctor before his visit what to look out for and what we think based on our intake. Once we do that, we start our balance testing. We use multiple tools depending upon where we're at. In the office here, we do the sensory organizational test. It's on a computerized Smart Balance Master or Equitest. If we're at an off-site concussion clinic, we use the SET or Stability Evaluation Test, which is on a computerized VSR Sport. We also use the VSR Sport for some of our baseline testing. We'll kind of cover that a little bit later. And then not so much anymore, but before we started using the VSR Sport on our off-site concussion clinic, we used the Balanced Error scoring system, which is using pen and paper. Let's talk a little bit about the SOT. It's the sensory organizational test. It uses the force plate to measure the subject's ability to maintain equilibrium while it systematically alters orientation information available to the somatosensory or visual inputs, or both. Basically, it's going to identify abnormalities with one of these systems, whether it be somatosensory, visual, or vestibular. During the assessment, the floor and the wall moves depending on the different condition that we're testing. Some are with eyes open, some are with eyes closed. This is a printout. There's 6 different conditions. Just quickly, I'll go through them. Condition 1 is eyes open. You're just standing still, nothing going on around you. Condition 2 is eyes closed, standing still, nothing going on around you. Condition 3, you move on to eyes open and the walls start to sway. 4 is eyes open and the floor rocks. 5 and 6, as you can see in this printout here, are red. Green is at or above average. Red would be at or below average. This particular printout shows 5 and 6 is abnormal. They're the vestibular system tests. That is generally where we see issues with the balance issues. 5 is eyes closed and the floor rocks, and 6 is eyes open and the walls and the floor rocks. We also use this particular testing. It can kind of give us an idea of when a patient is aphysiologic or faking, to be honest with you. We don't really see a lot of issues with balance after the first 2 or 3 days of a concussion. That's generally the quickest thing to come back. There's another part of the SOT. It's called the head shake SOT. It basically compares conditions 2 and 5 with another version of condition 2 and 5 with the head moving. We do, you can do a side to side, like you say, in no motion or up and down. So basically yaw, pitch, and roll movements. Basically for this test, we generally only use the side to side, and it's used more so for our higher level athletes, our gymnasts, our hockey players. It's just an added test that we put into play that helps us evaluate our athletes. This is a depiction of the printout you get, and you can see the different head motions there, side to side, up and down, and back and forth there. And it shows you the conditions 2 and 5 that it compares. The balance testing we do with the VSR Sport, it's a portable unit. It's an 18 by 30 inch force plate, and it measures sway velocity. It's based off of the same conditions as the BEST test, but it measures, like I said, the postural sway velocity over a period of 2 to 5 minutes. The different positions there, you can see double leg stance, the single leg, and then tandem. And you do it on a firm surface, and then you put a foam pad or mat on there, and you do the same conditions again. This here is a printout. Obviously, see you got a nice picture of your results. This particular one, everything's normal. You can see the green again. You get your scores of your 6 conditions as well as a weighted average at the end. And then last but not least, here's the balanced air scoring system. The biggest thing, it's better than nothing, but if you have other means of doing balance testing, especially the computerized stuff, it really helps because it's more accurate. You could have 10 people watch the BEST testing and get 10 different scores depending on what particular person feels or sees while it's going on. Next, we do vestibular testing. We use the Neurocommon Vision testing. It measures the patient's ability to maintain visual acuity or stable gaze while actively moving their head. We use the dynamic visual acuity piece as well as the gaze stabilization piece. The dynamic visual acuity, it measures changes in the visual acuity at head velocities associated with the VOR, or vestibular ocular reflex. This is a printout here. Basically, you do a static vision first to see how well a patient sees from a particular range. We measure all 8 feet here in our office. It depends on how much space you have in your office area where you're doing the testing. Then you do a perception time test, and then you put a controller on top of their head, and they do some head turns, and obviously it measures in the left and right direction. And you can see this one's for obviously printout purposes, it's very abnormal. Basically, the closer you are to your static vision, the less the bars are. So the taller the bars there on the display, the more impaired the patient is. The gaze stabilization is kind of like the head shake SOT. We do not use this on every patient, but we do use it on our more high-level athletes, our gymnasts and hockey players. We also, this is also used for professional hockey players that we see with the Carolina Hurricanes. The GST just measures the maximum head velocity a patient can achieve while maintaining vision, whereas DVA, you go a certain distance and a certain speed. With the gaze stabilization, each time you get your head faster and faster, and it measures how accurate your vision is the faster you get. So it is a little more advanced test, depending on the age of the patient, would be whether or not they could actually execute this test. The next testing we do is cognitive testing. Here at Raleigh Neurology, we use the impact and also CNS vital signs. There's many other tools for cognitive testing. These are just the 2 that we use here. This is obviously how we write notes for school accommodations. We determine how long they need to take off from school. Both of these particular testing tools are used in our school systems here for baselines in the high school level. So when they have a baseline at school, we can kind of see how they compare versus when they took their baseline. Unfortunately, the baselines that are done at school, they're done in a large group. So in a big media center or computer lab, sometimes as many as 20 to 30 kids in one room. So there's many distractions. So, excuse me. So they're not always as accurate as we like them to be, but they are better than nothing at all. And they can be very helpful, especially with kids that are below average or have learning disabilities, because it's kind of hard to know where those kids should lie with no baseline. The way we do the testing here, we put the individual in a quiet room by themselves to take the test. The testing takes about 30 minutes, 25 to 30 minutes. And we found that we get much better results in the quiet setting. After we finish with all of our testing, then we move on to the doctor's visit. These are just some little bullets that we do. In the doctor's visit, obviously your basic neurological exam. We talk about medicine, diagnostic tests, the forms that we need to fill out. The the diagnostic tests, range from any of the ones on the bottom of the form, the assessment form from earlier, from MRIs to EEGs to, there's certain things that we automatically do MRIs for, generally motor vehicle accidents, something that, like hard object to the head, a baseball, softball, lacrosse ball, head contact with concrete or ice. Obviously we do EEGs for, fainting or passing out spells, some kind of syncopal episode, or if there was any kind of report of possible seizure activity prior, during, or after the injury. This form here is our ADL form, activities of daily living. It kind of just goes through, we use this for our elementary school kids. Lets us know when they need to return to PE, when they're returning to school, gives them the academic provisions that they need, and then also when they can return to their sports or activities that they're doing. The next form is the Gefeller-Waller Return to Play form. This is the form for North Carolina. Our law, most states have laws now for how to treat concussions and how to return patients and athletes back to play. Our law came into effect in July of 2011, and this form here was created. It's been modified a couple times since then, but basically I'm not sure how well you can see it, but as the date of injury, their sport. If it happened at school, the athletic trainer fills out the top part. It just gives us some information about the mechanism of injury and the symptoms they were having at the time. If it didn't happen at school, then we rely on the patient and the parents to give us that information. In the middle section on the first page, it gives some school information, like when they can return. Like the first box says return now, and then, or you can put them out for a certain number of days. Then it talks about PE, and then it talks about return to sports. This is all the physical stuff. Then there's a backside to it that has the academic recommendations on it. I'm going to kind of go down through some of the ones, shorten day, and you can put in hours, shorten classes, take rest breaks. Mainly the ones we check are allow extra time to complete coursework and assignments and tests. Occasionally we lessen computer time or homework load, but not generally. The last three at the bottom we always check. Said no significant classroom or standardized testing at this time, as this does not reflect the patient's true ability. This is what we found to be very critical with our notes back to school. Even though the child may feel like they're fairly close to normal, we don't want any grades to be affected that doesn't reflect their true abilities, especially when they get into high school ages. Obviously every grade counts, and all 4 years count towards moving on to the next level, so we don't want them to not get into the school of their choice based on something that happened in 9th grade when they had a concussion. The next to last one just says check with return to symptoms when doing activities that require a lot of attention and concentration, and then take rest breaks during the day as needed. The bottom half is our gradual return to play. It's a 6-stage progression. Each days 1 through 4 is all cardio. Each day you get your heart rate up a little more and more each day. Day 1's a 20 to 30 minute walk and stationary bike. The next day's 30 minutes of more rigorous medium pace cardio. The next day you get it up higher and higher. Day 3 is like 60 to 80% of maximum heart rate, and then day 4 is 80 to 100%. If you can go through all those days, excuse me, each day symptom free, then you can move on to day 5, which is full contact practice. Depending upon what sports you play, you can go through days 1 through 5 symptom free. then you can return to full participation at whatever sport it is you play. Now we'll talk about the benefits of the dynamic visual acuity testing. To me, I get asked all the time, about the different tools we use, and to me, this is, if I had to give away every tool that I had to use, this would be the one that I keep. And I'll kind of explain that as we go. This is obviously the definition of DVA again. We talked about it a little earlier. And then of GST, gauge stabilization test. Basically every walk, every factor of life, we're constantly moving our heads in motion, spinning around, looking, depending on what we're doing, whether we're just walking, talking, classrooms, playing sports, driving, and the vestibular system can really be impacted with concussions, and the deficits can cause us not to be able to function properly or normally as we do in everyday life when we're normal. The severity, obviously, of the deficits play a huge role in how we function. There's also a possibility we've learned over time that obviously the patients can feel better and be symptom-free, but the vestibular system not be functioning at top performance. This is especially, this particular test helps us determine that based on the equipment, not based on what the athlete tells us. Boys in particular, they're not always forthcoming with their symptoms, so they want to get back to their activities, whether it be video games or a sport. And this particular equipment tells us the truth. And I tell parents all the time, it doesn't really matter what the patient says, the equipment doesn't lie. And we kind of got a good joke about it, and everybody laughs, but it is very important with this testing, and it lets us know when to send kids back. When the function has returned to normal, everyone always passes the test. It's just as simple as that. We also use this to determine whether or not a patient should be driving, which obviously is critical for all ages. Like I said, I do see adults, but the majority of what I see is kids. With driving, our head's always on a spinning around, seeing, picking up road signs, lights, judging distances of vehicles, reaction time, stopping, people pulling out in front of us, kids running out in front of us. It's critical to make sure that we're functioning properly before we let them go back to drive. Some negative consequences of mismanaged or undetected concussions. Just going to talk about briefly some bullets that I've written down here, and just some subtopics underneath each one. Just from the mental health aspect of concussions, the anxiety piece is huge when it comes to concussions. If there's a history of anxiety, a lot of times with the concussion, the anxiety, depression can actually get worse. It starts creating other things. So with these particular patients, we tend to have to get them back to some activities, not necessarily activities that would take a chance on bumping their head or that kind of stuff, but just somewhat keep them in their normal routine, because when they get out of their normal routine, they really fall apart, and you end up having more issues than you do with just a concussion. Obviously, concussions affect relationships with family members, friends, colleagues, school work, with the mood swings, the irritability, sometimes it's hard to figure out whether the mood swings and the irritability is just being a teenager or whether it's actually the concussion, but these are all symptoms and factors of a concussion that you have to take into consideration when treating them. The physical consequences, obviously, the headache, the balance, the dizziness, the list goes on and on. There's many of them. Obviously, they're all listed on that symptom checklist. You can have one or all or somewhere in between, and obviously it affects your daily life and everything you do in it. The headaches are probably the biggest complaint that we have, and usually the last symptom to go away. Performance, the focus, the concentration, reaction time, it goes on in your daily life, your schoolwork. Obviously, the ADHD kids they already have trouble focusing and concentration, and a lot of times with the concussions, it just makes it that much worse. A lot of times, we have to keep those kids active more so than others, also because they can't sit still. So when you start trying to put limitations on them, it just makes life more miserable, and next thing you know, you got more problems than you had with just the concussion, similar to with the anxiety and the depression. The academics, obviously that's a huge part of the pediatric population that we see. Just some of the issues we see is the memory loss, the reading comprehension, the attention. We kind of talked about the ADHD before. The fatigue, being tired. We talked about with the form earlier, the Fellow-Waller form. We don't want their grades to be affected, so we have to make sure we write notes and accommodations. If for some reason, sometimes we get kids that have gone 2 weeks without being seen or assessed by anyone, so they've gone to school for 2 weeks and struggled and had a lot of issues in school. Next thing you know, the grades are dropping, and that's something that we really try to get a handle on quickly. We like to see kids as early as possible. We used to kind of think that it was okay to wait a week before they came in, but we've learned over time that we need to get the testing done so we can assess them and write proper notes, and that way everything from not sending them back too early to sports and also the academic piece all can be bundled up, and notes can be written appropriately and distributed, so you don't have issues long-term, any more long-term than you already do. One thing we already know kind of just from some of our testing, obviously we talked about earlier, the younger you are, the longer it takes to heal. Basically you're talking about 10 to 12-year-olds generally take a minimum of 3 weeks to recover. Whereas, kids on up, juniors and seniors in high school and even college age, 10 to 14 days, they can be pretty close to back to normal. So this is where, treating them, early and getting everything tested and seeing where they're at can kind of help you with the recovery process. Plus, there's a big education piece of letting them know what to do and what not to do. Parents that it's the first concussion of the family, a lot of times you have a lot of panic and they don't really know what to do. They've heard different stories and stuff, so you just kind of want to settle them down and give them the information they need and the proper documentation, and hopefully put their mind at ease. Next, I'm going to talk about some tips, marketing tips that we've used, or not necessarily intentionally, sometimes by accident, but things we've learned over time about how to promote the concussion management services. The biggest thing about any program, it is about building relationships, whether it be with the patients, the parents, the school system, the athletic trainers, other doctors in the area. We're going to kind of talk about some of the people that we partner with and some of the things we do with those folks. The local hospital here in the area, we started a sports concussion clinic about 9 years ago. It basically we started it on Saturday morning, basically with the hopes of seeing kids after Friday night football, and also with the hopes that both parents could come to the appointment since it was on a Saturday. It evolved into, we moved away from Saturdays because it didn't quite work out the way we thought it was going to, but it evolved into 1 day a week in the spring and fall to 2 days a week in the spring and the fall, as well as obviously we're still seeing patients in our clinic here at our office. We partner with those guys. We do baselines with different sports teams, the high school. We do research with these guys, and we also provide education for the nurses and some of the doctors, the ER physicians. We set up kind of guidelines of when and when not to do a CT. Generally, most CTs are negative, but they don't show the big picture always. So there's some criteria that were set up and put in place, and they have a checklist now at the ER. If they're exhibiting one of these 5 things, then you do a CT. If not, if they don't check box any of them, then you don't. Obviously, it keeps the kids away from the radiation and also unnecessary costs for the parents. We partner with multiple sports medicine and family practice groups. We also do community outreach, education for coaches and parents, do baselines as well, different sports organizations, hockey groups, football groups, soccer clubs. We do research with those guys as well. The UNC Fellow Waller TBI Research Center, those guys do excellent work there. They're doing a lot of work with NFL now and trying to get some research done to get a handle on some of this stuff you've been hearing in the media. And we're currently doing a research, pilot research study with those guys now for concussion versus headache. Migraine headaches are very similar symptoms to concussions, and sometimes it's really hard to tell the difference. So if you have a child that has a history of migraines and then they bump their head, the symptoms are so similar, sometimes it's hard to tell one from the other. Obviously, we end up treating them the same, but this research study is basically we do the concussion testing, and then once they're cleared and they go back to their normal activities, they have a headache, they call us, we bring them back in, we do the same exact testing that we talked about earlier, and then compare the results of when they had a concussion versus when they had a headache, obviously with no blows to the head or no bumps or falls. And we're still in the early stages, so we don't really have any data to show anything, but we definitely know that the results are somewhat similar, maybe not as bad sometimes with, but they are showing impairment when they're having the headaches. We partner with schools. We pay for baselines. Like I said earlier, the impact and the CNS vital signs are used for baselines in our school systems at the high school level. Some of the outlying schools in rural counties didn't have the money to pay for these baselines, so we started it into the school system. We currently pay for a couple different schools. We've got it instituted where now the actual booster club is paying for them in certain other schools. We partner with the athletic trainers. A lot of the athletic trainers have a direct line to me, so I get calls 24/7 from those guys when they have questions or need to get athletes in. And we also do the education piece with them as well, speak to coaches, also go to parent meetings and that kind of thing. Primary care providers, Dr. Wooten in particular goes out and does a lot of educational talks with them, and there's a pipeline. They have my phone number as well, so when they have questions or need to get a patient in urgently, they can call me, and we generally try to work them in the very next day, if at all possible. The last two here are more or less people that we partner with that we send patients to when we see the need. Obviously, physical therapy for the vestibular therapy piece. There are some exercises that we give here in the office sometimes to help with the recovery process, but when the deficits are a little more severe, we send them out to a vestibular specialist, and also neuropsychology. Obviously, the cognitive testing we do is just a mini version. When we have deficits that linger on a little longer than what we normally anticipate, we send them for a full-blown neuropsych evaluation. And we have a picker group that we partner with, and we get the results back and get them in fairly quickly as needed. There's a reference to the American Academy of Neurology, just a couple websites. You know, with the internet, you can find a lot of information, some good, some bad, some right, some wrong. We generally try not to use too much information unless it comes from a particular source that we know we can trust, like the American Academy of Neurology or the CDC. They have good information about concussions. Obviously, our website here at Raleigh Neurology is raleighneurology.com. We have all our services listed there as well, and I've also put NATIS on here at the bottom. If you want some more detailed information about the equipment and the testing. If anyone has questions that do not get answered in this presentation and they would like to contact me, my email address is my name. It's my first letter of my first name, Mike, so it's M. Hales, H-A-L-E-S, at raleighneurology.com. And now I'll turn it back over to Mary, and we'll answer any questions that you have.
Thank you, Mike, for this informative meeting. Please visit our website at nervecenter.natus.com or balanceandmobility.com for information on upcoming eSeminars or to access previously recorded meetings.